Once the MDGs expire at the end of this year, will we continue to address lung health in silos or in an integrated manner in the post-2015 Sustainable Development Framework? That is a point to ponder upon. The cost of lung disease runs into billions of dollars each year in lost productivity and increased healthcare expenses, to say nothing of diminished and ruined lives. Yet, public demand and political commitment remain inadequate to effect significant changes. For example, I remember the New York Times carried a series of articles in the past on different parts of the human body, but forgot about the lungs. That is why the union and partners had declared the year 2010 as the year of the lung. The connection between life and breath is fundamental, yet the evidence shows that lung health is not high on the public health agenda. Let us hope that this will change beyond 2015. Today we have an esteemed panel of experts from the International Union Against Tuberculosis and Lung Disease and TB Alliance, who will talk about lung health beyond 2015. Before I hand over the webinar moderation to award-winning journalist and commentator Ashok Ramsarup from SABC in South Africa, please allow me to make a few announcements. It is my humble request to panelists to please make their expert remarks in 10 minutes. That's the time we had requested you for. We will sound a beeper. We have a friendly cricket in our office, and we will sound a beeper like this at the 9th minute. That's our friendly cricket. While panelists are presenting, participants can send us their questions using the chat function. They can also raise the virtual hand during the question and answer session. But questions on chat can stream in any time during the presentations as well. Over to you, Ashok. Is Ashok Ramsarup there? I think he is not there for some reason, maybe some technical problem. Let us waste no more time. I would like to introduce the three panelists. Our first panelist is Dr. Riitta Dlodlo. Dr. Riitta, excuse me if I'm pronouncing your name incorrectly. She is Director of the Department of TB and HIV at the Union from Zimbabwe, and she will be our first presenter. Our second presenter is Joanna Breitstein, Senior Director Communications, TB Alliance, and the third presenter is Paul Jensen, Senior Advisor Policy at the Union. We will take the questions after all three panelists have made their remarks. The WHO End TB strategy envisions ending TB by 2035. Let us listen to Dr. Riitta from the Union on how will TB and HIV responses look like beyond 2015. Over to you, Riitta.
Thank you very much, Rahul. Good afternoon, good morning, and perhaps even good evening to some of you from the Asian hemisphere. Thank you firstly for inviting me to participate in this webinar, and thank you also for posing the very important and interesting, fascinating question, lung health beyond 2015. I will be talking from the perspective of tuberculosis and HIV, and particularly the interface between these two conditions. I will be focusing very much on my vision and dreams regarding collaborative tuberculosis and HIV activities for the benefit of the patients who have both conditions and sometimes also a number of other comorbidities. As we are aware, the new current NTB strategy is the third global TB control strategy. The very first strategy was launched in the early 1990s when WHO declared tuberculosis a global emergency. That strategy was one of the shortest plans. It consisted of 5 fundamental components of the so-called TOTS strategy for tuberculosis control. At that stage, we did not clearly see sorry for the noise behind me. There seems to be a railway track just in the vicinity. So in the early 1990s, even though we could see the increase in the TB workload, we did not quite associate it correctly to the emerging HIV epidemic, not even in the high HIV prevalence areas. And therefore, this strategy is actually interestingly silent regarding HIV infection and AIDS. However, by 2006, when the Stop TB strategy was formulated, TB-HIV activities were prominently displayed. And the early 2000s also saw the interim policy and guidelines for collaborative TB and HIV activities, including the 12 components as we know them more or less now. However, End TB strategy clearly places collaborative TB-HIV activities in Pillar 1 and Component C, which talks about patient-centered, integrated and comprehensive high-quality services for patients. It is disheartening to note and recognize how so many countries and so many national tuberculosis programs and so many national HIV/AIDS control programs, with the support and under pressure from media, civic organizations, patients' organizations, and various other pressure groups, have taken on board and on their agenda the collaborative TB-HIV services and accelerated these activities or services, patient or health services, to levels which we could not imagine, for example, some 10 years ago. I think our greatest challenge in the post-2015 era will be to sustain these achievements in view of the fact that every quarter, every year, and naturally every quarter and every year starts with every single day, we will diagnose and register and notify tuberculosis patients who may benefit from HIV-related services and whose entry point to these services needs to be opened by offering provider-initiated HIV testing and counseling. So we have to provide these services for every cohort of requires a medical treatment or taking of daily treatment for the rest of one's life. And therefore, you need to look at patient cohorts who were started 1 year ago on ART, 2 years ago on ART, etc. This means monitoring and keeping track on ever enlarging patient populations. This is called ART retention. In addition to ART retention, we want to provide quality care for these patients who may or may not have developed a new or another or any TB episode, because we actually wish that through test and treat we will be able to reduce TB incidence, new cases of tuberculosis. The measure for quality HIV care from the medical point of view is the measurement of viral load. That should be undetectable among these patients. That shows that their degree of infectiousness is as minimal, as close to zero as it possibly can be, and that the antiretroviral treatment is working, so to say, in the patient who is taking his or her medication. Viral load measurement will also indicate fairly early on when the patient may be in an early stage of virological failure, ART failure, which requires further medical attention and considerations for changing of the ART regime. Naturally, quality of care is not only determined by the medical indicators, such as viral load measurement. It requires several other psycho, emotional, and socioeconomic aspects, but I will not go into them at the moment in view of the limited time on this panel. I would like to proceed and mention a very short case study pertaining on my own country, Zimbabwe, situated here in Southern Africa with a population of 13 million. We are unfortunately one of those countries where we have experienced an HIV-fueled TB epidemic. Our resources are also limited, and due to various socioeconomic upheavals, our country has suffered great brain drain, and a lot of our health professionals, doctors, nurses, laboratory technologists, environmental health technicians, recording and reporting M&E specialists have left the borders of our country. In spite of our challenges, national challenges, we have admirably been able to accelerate, particularly those components of the TB-HIV collaborative activities that aim to reduce the HIV burden among TB patients. To illustrate this, I would like to share with the panelists and you, dear audience, a few figures. The PITC coverage is currently between 95 and 97%, meaning that majority of the patients, TB patients, know their current HIV status. We started some 5 to 10 years ago at very modest levels of just a few tenths of percent, 10, 20, perhaps 25% of our TB patients knowing their status. At the moment, based on the 2014 data, 69% of the TB patients are also HIV infected. The cotrimoxazole preventive therapy prevalence or uptake is also close to 100%. The key finding pertains to the ART coverage, which was only 44%, ladies and gentlemen, in 2010. It increased to 60% 2011. It was 75% in 2012. And 2013 cohort information indicates 81% of ART coverage. I can see that my 10 minutes is about to be up, and I would like to upload my country colleagues and all of you in the international sphere who have stimulated and encouraged the Zimbabwean health professionals to push for this marvelous performance. I believe that if Zimbabwe, in spite of our current challenges and challenges over the past years, can make it, that everybody can really make it. And indeed, we are very seriously facing the challenge of sustaining the gains and achievements that we have made. Thank you very much. I thank you for your attention.
Thank you very much, Riitta, for a very, very informative presentation. And I see that Ashok Ramsarup ji is here with us. So I welcome him. He's a noted award-winning commentator and senior radio program producer from SABC. So Ashok will now introduce the next speaker, and we will proceed. Also, I would request the listeners to please use the chat function to send in their questions. Thank you.
Thank you, Jean. Thank you kindly for this very golden opportunity. I want to say I bring you special greetings from South Africa. I need to say thank you to Dr. Dlodlo, Director of the Department of TB and HIV, International Union Against Tuberculosis and Lung Disease, the union from Zimbabwe. Thank you very much. And perhaps I would like a special, well, I request our second panelist to make some comments, perhaps. Her name is Joanna Breitstein, Senior Director, Communication, TB Alliance, Global Alliance for TB Drug Development. It's over to Joanna.
Many thanks, Ashok, and many thanks to the team at Citizen News Service for organizing this webinar and bringing people who are passionate and interested in this topic together. If I could just have a bit of help from the organizers, I have a few slides to share. Is that possible?
Yes, yes.
Great. So I believe that's just turning now.
Yes.
And I'll just...
yes, we can see it.
You can see it? Okay, great.
Yes.
Many thanks. So as mentioned, thanks Ashok for the introduction. As mentioned, I'm Joanna Breitstein, Senior Director of Communications for the TB Alliance. The TB Alliance is a not-for-profit organization with the mission to discover and develop better, faster, and affordable TB drugs that are available to those who need them. Today I'd like to focus my remarks on pediatric TB, childhood TB, which really has been neglected for far too long. TB is a significant cause of illness and death among children, but historically has really been deprioritized as a global health and humanitarian issue. Part of the reason for that is because it's difficult to diagnose children with TB. Children get TB the same way adults get TB, but their symptoms tend to be less specific. And that has given, if you add in the challenges with diagnosis, that's led to systematic underreporting and really a lack of attention to the problem. In 2012, WHO began publishing age desegregated data. And really the estimates are such now that we know there is more than 500,000 children each year that acquire TB, and 80,000 children die. It's important to remember that these numbers don't include deaths of children with HIV. So certainly these numbers are higher, and I think a question that's still out in the public health space is just how much higher are those numbers. I think pediatric TB stands out in another respect. Over the last years, we've had some good news and improvements in child survival, such as HIV and pneumonia, as the last presenter mentioned, really stemming from funding, from new treatments, and attention to these problems. But those gains and those improvements in child survival have not been realized for children with TB. As I mentioned, childhood TB has been neglected, and it is an issue that wasn't really addressed for far too long. The WHO's childhood TB subgroup really began to change that effort over many, many years. And in 2003, the Childhood TB Roadmap was published. This was by WHO and their partners, and really drew increased visibility and advocacy on pediatric TB. Since that time, there has been some movement and a number of accomplishments. In high-burden countries, there's been improved guidances and training materials for TB programs on the management of TB in children. And the TB Alliance and WHO received a grant from Unitaid, which I'll talk about in a minute. We also have a much better understanding of the burden of pediatric TB, both in terms of the numbers I mentioned and additional studies being conducted by other parties. So finally, there are a number of people around the world who are looking into this issue. As we move forward with the NTB strategy and the Sustainable Development Goals, we see more ambitious targets, truly thankfully, for children with TB and TB in general. When I look at the NTB strategy and the Sustainable Development Goals, I'm very glad to see that there is a focus on vulnerable groups, including children. And both in terms of TB and pediatric TB, there is this focus on the need to develop new treatments, and that it is only through new treatments that we are going to radically impact the pandemic. The next slide I'd like to share with you is from the NTB strategy, and you often hear the phrase in public health of bending the curve, and here I think that really illustrates that. You can see if things go on as they are, we can only decrease TB by about 1.5% per year. That's not that much, and it's certainly not fast enough to end the epidemic. We really need new tools, and this graph shows the impact or the potential impact those new tools could have. So in terms of where we are today with pediatric treatment, the treatment is too long, it's too difficult. And that's true as well as for adults, but children have additional challenges. For drug-sensitive TB, children need to take treatment for 6 months. And for multi-drug resistant TB or MDR TB, the treatment can be 2 years or even longer. The WHO revised their treatment guidelines for children with TB in 2010, and that was a really big moment. There was a recognition and much work done that proved that children were not getting enough drugs. They were not getting enough medicine in their tablets. However, since the WHO revised their guidelines in 2010, no child-friendly TB drugs for children have come out in the new higher doses. What's more, when we look ahead, the situation looks difficult. We see huge gaps of time between when new drugs for TB will be available and their companion child formulations. I want to focus for a couple of minutes on the situation today. I mentioned before that the TB Alliance and WHO received a grant from Unitaid as well as USAID in late 2012 to really take on sort of the biggest problem and the most immediate problem of the current drugs today. That's for drug-sensitive TB, which affects the most children. So ever since the WHO revised their guidelines in 2010, providers around the world have had two flawed options in terms of providing medicine to children with TB. They could either give children medicine in child-friendly doses that dissolve in water, but they were in the wrong dose, child-friendly forms, but in the wrong dose so that there was not enough medicine. Or they can go through a very complicated process of trying to chop and cut pills, mix them with food. These are very foul-tasting, bad-tasting pills to try to get to the new higher doses. And in the slide that I'm showing now, you can see some of that process. Clearly, that's very difficult to do, certainly every day for 6 months. Some of these pills need to be chopped in thirds or crushed. And that leads to, a lack of optimal treatment. Around the world, this is sort of this ad hoc way of treating pediatric TB, and it could lead to poor outcomes and certainly drug resistance. just wanted to take a moment to show the audience what a day's worth of drugs for second line for MDR TB look like. Here is a child, again, with 1 day of drugs for MDR, TB, and HIV. And you could just see the amount of pills that need to be taken. This does not even include the injections that are often needed for the first 6 months. So with the grant from Unitaid, TB Alliance and WHO has moved forward, and we're very excited. This is an exciting year for, I think, the whole community, and that we are preparing to introduce simple, child-friendly formulations of the first-line TB treatment for drug-sensitive TB. These will be fixed-dose combinations, and they'll contain the correct WHO-recommended doses in the drugs. So our hope is that truly with 1 or 2 fixed-dose combinations that can be dropped in a small amount of water, dissolved in just a few seconds, that we can really improve treatment of TB in children and at least give providers adequate tools as a first step. So we expect that to happen this year, and I think that will be a real seminal moment. But we know that the work is still ahead. So really in 2016 and beyond, we really need to call upon a wide variety of stakeholders. It's not enough to have the right drugs, but you need to make sure they get to the people who need it. And here we need everyone to play a role, whether that's countries, TB programs, even maternal and child health programs, donors, others, and certainly the media, to raise awareness and truly advocate for adoption of these correct first-line TB formulations that are now coming to the market. We can also view the coming years as an opportunity, not only to use the new drugs, but to use the opportunity of simpler treatment to make treatment of pediatric TB easier. So this includes the opportunity of moving outside the TB programs to other programs, whether it's HIV service or maternal and child health programs, where children might present with TB and would otherwise not be diagnosed and treated. In the coming years, absolutely, we need development of child-friendly forms for second-line drugs. That's going to possibly be even more difficult than getting the first-line treatments because the market is so small and the potential profit for manufacturers is really minimal. However, this is an urgently needed global health need, and we need donors to step up to make that a reality. Finally, we need to accelerate the research for new, faster-acting treatments for children. And this really is the challenge over the coming years to truly, as we say, bend the curve and make sure that any new progress that's being realized for adults can be quickly realized for children. Right now, bedaquiline and delamidate over the last few years have been conditionally approved and are now available in some countries. But it will be many, many years before those are available in child-friendly formulations, and that's simply not acceptable. Finally, it's important to look back and say neglect got us to where we are today. In 2015 and beyond, we can't let that neglect characterize our efforts, not for pediatric TB and not for the field as a whole. The Childhood TB Roadmap estimated that between 2011 and 2015, we needed $200 million to get the needed pediatric tools to market. You know, by 2013, just halfway through that time, just $25 million was spent on pediatric TB R&D. And while that may sound like a lot in terms of absolute dollars, really it's just a fraction of what's needed and certainly not commensurate with the size of the problem or the need for new treatments. In closing, I'd like to just ask the audience for their advocacy in this area to both raise the awareness of pediatric TB, the coming availability of new treatments, and really the need for funding both at the country level and the international stage to fundamentally change where we are in this field and certainly for a better tomorrow. Thank you so much.
Thank you very much. Thank you very much. That was Joanna Breitstein, Senior Director, Communications, TB Alliance, Global Alliance for TB Drug Development. Moving on, let's now get to our next panelist, or rather to hear our final panelist today before we open for questions and answers.
I think Paul is not there for some reason. So we will go directly to the question and answer session.
Sure. Great.
Yeah. So we have a journalist from Zimbabwe who wants to know, this is a question for Riitta.
Yes.
Alice Tembe from Zimbabwe. She wants to know, did Zimbabwe experience increased DRTB in the past 3 years, noting their success in ART coverage?
Go. Comments?
Sorry, I didn't quite hear the question. Do you mind repeating it?
Okay.
Please.
Yes, I will. Did Zimbabwe experience increased drug-resistant TB in the past 3 years, given their success in ART coverage?
Thank you. Thank you very much. I think when we talk about antiretroviral treatment rollout, and when we, on the other hand, talk about a certain type of tuberculosis, in this case, the drug-resistant type of tuberculosis, they are two different issues. There's an association between HIV infection in increasing the chance of a person with latent TB infection developing active tuberculosis. And depending on the strain of the TB bacillus in this person, the active disease could be drug susceptible, also perhaps called commonly ordinary TB, or drug resistant tuberculosis, and one form of it would be the multi-drug resistant tuberculosis. However, when a person who is HIV positive has been started on antiretroviral treatment, and as the person's immune responses improve thanks to the positive impact of these antiretroviral medications, the likelihood of breaking down with active TB disease is decreased by up to 50 to perhaps 80%. I note that the person posing this question is from Zimbabwe, and you have probably seen in the mass media, or you have heard from other sources, that we are also diagnosing more drug-resistant TB patients. So this is not necessarily related to ART. I think that the increasing number of patients with this condition is more related to the fact that Zimbabwe has started from 2012 to 2013 to roll out the new rapid molecular technology. That is a new groundbreaking test for diagnosing tuberculosis. We all know it by the name of ExPERT or GeneXpert. Besides diagnosing the presence of Mycobacterium tuberculosis, or the TB bacillus, the TB germ that causes tuberculosis, this new test can also test for rifampicin resistance. And rifampicin is one of the cornerstone drugs for treatment of tuberculosis. So in patients where the result indicates presence of rifampicin resistance, drug-resistant TB, even multi-drug-resistant TB, can be seriously suspected and further investigations are required. So you're quite right. Thanks to having more access to this new test, we are finding more patients with the condition. And our health services have a great challenge in ensuring that these patients are then started on appropriate special treatment for drug-resistant tuberculosis. This treatment can be given in patients who are taking antiretroviral treatment as well as co-traumatic preventative therapy, so it can be given to patients with both conditions. However, the nurse, the ART or HIV nurse, and or the doctor should ensure that certain drug combinations are not used to ensure efficacious treatment. Let me pause here and hear whether I have answered the question to the satisfaction of the person who asked it.
Very well answered, Riitta. Thank you. The next question is from a journalist from India, Vivedi. The question is to Joanna. What can be done at the country level to improve TB responses for children?
Thank you for that question, Shobha, and to the person who posed it. I think many things can be done at the country level to improve the response to pediatric TB, certainly. It's important to understand the setting of the national guidelines and whether countries have first adopted the WHO guidelines that recommend the new updated dosing treatment. It's important to understand that in terms of the different country perspective, to understand where that country is on the pathway towards adoption of the new treatments and ultimately improving treatment. But whether or not your country has adopted the guidelines or not, there's still a lot that can be done from multiple different levels. For journalists and people working in advocacy and civil society, I think one of the primary things that they can do is draw attention to the problem. And TB is often considered a disease of the vulnerable, but children with TB are some of the most vulnerable even without that group. So really drawing attention to the problem and noting that much can be done to improve diagnosis and treatment of children, that they can be cured, I think is a critical first step for anyone working in the media or advocacy areas.
Okay, thank you. Another question for Riitta is from a journalist from Philippines. What cost-efficient approaches did you do in Zimbabwe to increase TB-HIV collaborative implementation? Nenet from Philippines.
Thank you. If I heard correctly, you are asking about what prompted and what assisted Zimbabwe to accelerate the response regarding collaborative TB-HIV activities, correct?
Cost-efficient approaches. She's asking for cost-efficient approaches you do in Zimbabwe.
Oh, okay. Sorry. This is sort of cracking a little bit, and I think it has something to do with my relatively low bandwidth over here.
Okay.
You have posed a very difficult question, dear listener. I'm not aware, in spite of our TB-HIV epidemic being quite well documented and studied, but I'm not aware of a study from the health economic point of view. However, if we think about the early mortality in HIV-positive tuberculosis patients, which can be very high, especially during the first 3 months or after initiating TB treatment, if antiretroviral treatment and if no CPT has been initiated, I think we have made a major saving regarding loss of human life, as well as prevention of severe ill health and human suffering. And nothing to say of the repercussions to the person's family, person who may be appearing to be terminally ill and having a condition which has definitely prevented him or her from, for example, working or engaging in any economic activity. So I'm sorry I don't have figures at my hand. Perhaps this could be a topic for a future webinar. I would also invite a comment from a fellow panelists, and I'm aware that South Africa, for example, has costed in US dollar terms the cost of delayed rolling out of, for example, nevirapine for mother-to-child transmission programs. That was perhaps some 7 or 8 years ago. Let me pause here and hear if, for example, Ashok has some information on his fingertips on the question.
Can I come in? Hello.
Yes,
can
please.
I come in?
Yes, please do.
Sorry, I just want to play a very important clip that we had done an interview with a professor from the University of Cape Town this morning, and I think this is relevant to this particular topic. And I'll just read the introduction and play a very small clip for 40 seconds. Lung disease is a major disease affecting millions around the world. A South African researcher has indicated that about 500,000 TB patients are diagnosed annually, which is just one of the lung-related diseases. Associated Professor Richard van Zyl-Smith, head of Clinical Research Unit at the University of Cape Town Lung Institute, says that 25 million people who smoke cigarettes contract respiratory diseases, ultimately leading to lung cancer. Professor van Zyl-Smith explains. I will play the clip.
If you look at the spectrum, there is a multitude, because most of the major diseases prevalent in South Africa affect the lungs. So you could include all TB patients, so expect something in the region of 500,000 new TB patients each year, those that have had TB. You could then include asthmatic patients, those with emphysema from smoking, and then all the patients who are in the mines who are exposed to silica and dust. Additionally, will have long-term lung disease. So lung disease in South Africa is actually very prevalent because most of the epidemics in healthcare also affect the lungs.
There's another small clip I'd like to play very quickly. According to Professor van Zyl-Smith, several million premature deaths are linked to air pollution, but new research today is proving successful in detecting the diseases early. This is how he sounded.
We have certainly got new diagnostic tests, so tests to test for lung disease. For example, the gene expert that's used to test for tuberculosis. The new CT scanners are also, and PET scanners are special ways of imaging the lungs. And then we have a lot of new medications for treatment, particularly asthma and emphysema, and obviously new drugs that are available for tuberculosis. So there's been quite an advance recently in technology, both to diagnose, but also in terms of investigating and managing lung disease in South Africa.
Perhaps I would like Dr. Riitta Dlodlo to perhaps make some comments on these issues.
Thanks, Ashok, for that very
Thank you
good
very much,
intervention.
Ashok, and colleagues in South Africa.
There's another question for Joanna. Hello.
Hello, can you hear me?
Hello. Yes.
Can hear you.
There is a question for Joanna from Philippines. What makes it difficult for some countries to utilize bedaquiline to treat TB?
Thanks for that question. I'm not a clinical expert, but I can certainly give my view. And then Riitta, I'm not sure if you might have some additional comments for that. I think one of the challenges that we're hearing regarding bedaquiline is, first and foremost, access to the drug. So the drug isn't, in fact, available in every country where it's needed, and I think some countries have some concerns about the pricing. But if the drug is actually being able to be accessed and to be paid for, there's still many, many challenges. One of the great things about bedaquiline is that it was approved rapidly so that people in need can get access to it. But one of the downsides of approving a drug early is that we don't have a full data set from which to draw upon. So, for example, bedaquiline did not yet go through its what's called a phase 3 trial, which is a large, long-term study to truly understand how long it should be treated for, how long it should be used for. I think folks are using some guidances within country, but one of the differences from that approach to one that the TB Alliance is taking is really to ensure that when we test drugs, we test them in combination. So this idea that one new drug should come to the market is in some ways a false idea. Bedaquiline is certainly an advantage, and it can certainly improve dramatically the chances of a person's outcome. But bedaquiline is added to a background, must be taken with many, many other drugs for long periods of time, and that could have significant side effects. And I think take that, and then you add in the fact that bedaquiline is a new drug, that it has some warnings around it. I think that has posed some challenges to providers on the ground.
Thank you. I think Paul is there, so we would like Paul to please make a small comment. Hello, Paul.
Hi, can you hear me?
Hi, welcome to the webinar. Would you like to make a small comment?
I would. I'm so sorry. I had a calendar issue, and it got mixed up, and I thought it was at 8 o'clock, and I was early, but I'm actually very late. So, would you like me to comment to the question? I actually did not hear the question. I just heard the answer. Can you repeat the question, please?
Okay. Yes, there is one question from Nigeria. For people living with HIV, do we need collaborative activities, also diabetes and other NCDs, in addition to TB and HIV?
Yeah, I think that the short answer to that question is yes. And if you look at the collaborative policy framework that was put out just a few years ago by WHO and the union together, it provides some basic recommendations for how to address TB and diabetes. And basically, it can be summed up in the words bidirectional screening or two-way screening, which just means that it's recommended that there be screening for TB among people with diabetes in countries where there's already a high prevalence of TB. So in countries with a high prevalence of TB, it's recommended to screen people with diabetes for TB. At the same time, it's also recommended that all people with TB should be screened for diabetes. So that's where this bidirectional screening term comes in. But to do that actually is going to require more collaboration than what we have at the present between different parts of the health system at different levels, at the national level, even at the district level and at the city level. So that's something that is going to be a challenge for health systems that currently are more set up for people working in infectious diseases to collaborate. But we don't see a whole lot of collaboration right now between the areas of infectious diseases and non-communicable diseases. So this TB diabetes challenge is going to be a significant challenge for health systems, especially in low and middle income countries.
Thank you, Paul. We have a participant from Kenya, Dorcas Kiptoi. She would like to make a comment and also ask a question, and maybe Paul can respond to that question.
Sure.
Dorcas.
Thank you very much for this opportunity. I'm not from the media, but I work for the Ministry of Health in Kenya as the head of the Tobacco Control Unit. And as you are all aware, tobacco use and exposure to tobacco smoke is a major cause of lung disease, and also makes worse lung disease particularly among children. I was wondering how the media in the respective countries, particularly those who are parties to the FCTC, what efforts they have made to engage government to include tobacco taxation in their domestic public financing for development. Secondly, I would like to request if also the union can ensure or work towards ensuring that tobacco taxes are earmarked for health interventions for lung health, and also to provide cessation among TB patients or patients with lung disease, and also to prevent chronic obstructive airway disease. Thank you very much.
Hi, yeah, this is Paul. Thanks. I think those are both excellent questions. I don't want to get out ahead of myself. And the question regarding media coverage, you know, I can't speak with specificity around what the exact role of media coverage has been. I think it's definitely important if we look at other health issues, and tuberculosis, where I'm most familiar. There has been research actually that shows that when media coverage of TB increases, funding and political attention for TB also follows from that media coverage, and not just in one country, but in other countries where, not just in the U.S., but in other countries where this has been looked at. So in general, I am a strong believer in the power of the media to shape political agendas. Beyond that, I can't say with certainty what the role of the media has been on the tobacco front. I can definitely follow up with our tobacco control colleagues within the union to try to get some more specific perspective, if you'd like. And the same goes for the tobacco control question. The union does have tobacco control experts who are daily working on the front lines of tobacco control. So I think the best thing for me to do would be to put you in touch with my colleagues in that office.
Thank you, Paul.
Thank you.
We have a question from Myanmar.
Riitta here.
Yes, please.
Let me just mention, in addition to what Paul has just mentioned, that smoking is yet another risk factor for developing tuberculosis, just like diabetes mellitus or HIV infection. And actually, the association between TB and smoking tobacco has been recognized for decades, if not centuries. And I'm pleased to say that Union has a guide for smoking cessation among tuberculosis patients. And I would say that it's very applicable, actually, to provide cessation guidance for any patients with any type of lung health or lung disease. I can provide it after this webinar for our organizers, or I invite the listeners and participants to log into the union's website. It's available, downloadable, free of charge. Thank you.
And this is Paul. One follow-up comment too. In the International Journal of Tuberculosis and Lung Disease, which the union publishes last year, there was a really interesting study that was done in Taiwan, looking at exactly what was just explained, how tobacco is a risk factor for people with TB, and it found that even among people who have been cured for tuberculosis in the past, if they're a regular or a frequent tobacco smoker, then their risk of acquiring TB again was more than double the risk among the general population. So I think it's important to think of tobacco as a risk factor for people getting TB the first time, but also for getting TB again in the future, even after they've been successfully treated before.
All right. We all know that Union has done commendable work on TB and HIV collaborative activities in Myanmar. We have a participant from Myanmar, Luin, who is asking a question that is mortality rate high in TB patients co-infected with diabetes?
Is the question, is mortality high for people who are co-infected?
Yes, mortality high in TB patients co-infected with diabetes.
Yeah, that's exactly right. It's mortality is higher, complications during treatment is higher, and in general, the risk factor is also higher. So the data are showing from multiple studies now that people with diabetes are 2 to 3 times more likely to develop tuberculosis than people who are not living with diabetes.
Okay, thank you panelists, thank you participants, thanks to our moderator, Mr. Ashok Ramsarup. It has been a very enlightening webinar. I'm sure all of us enjoyed listening to the experts, and we promise to send the webinar recording and other reference material to the participants within the next couple of hours so that they can develop their news articles around the webinar. Thanks to each one of you personally, Joanna, Riitta, and Paul, and Ramsarup. Thank you.
Thank you very much.
Thank you.
Thank you very much.
Bye-bye.
Bye.
Bye-bye.
Bye.
Have a good day.
Bobby.